Okay, so he, like these cancer screening are very important, doctors. Okay, so write down colorectal cancer, breast cancer, cervical cancer, prostate cancer, and lung cancer, and skin cancer. And you should know how we screen melanoma, and non-melanoma cancers. Okay, so these are the mainly very important for AMC. Okay.
Please repeat.
Yeah, doctor, I can repeat. Breast cancer, cervical cancer, breast cancer, cervical cancer, then colorectal cancer,
Colorectal, prostate.
yeah, prostate, then skin cancer, and lung cancers. Okay, these are the high yield for AMC screening. Okay, so we will discuss one by one. First of all, we can discuss about, okay, start from the colorectal cancers, right? Yeah. So, colorectal cancers. So, you already know about the colorectal cancer, but it's fine. We will start from the, yeah, Dr. Bhagyas type in, and if someone has missed it, you can just take it from them. Colorectal, breast, cervical, prostate. Then you have to add the skin cancer and lung cancer as well. Okay, yeah. So let's start. Okay, here. Okay, this is the Red Book 10th edition. Yeah, this is the 10th edition. Don't use 9th edition because the age is different. Okay, so you have to use this one, the new guideline. This is the 2025 edited one, last updated one. So I have shared the same guideline and you can find it from here. So let's find out about colorectal cancer. Okay, this is the okay. Before screening for the cancer,
Um,
you should,
should all guidelines be studied from Red Book only?
yeah, screening usually we use Red Book. If we can't find something in Red Book, we have to use in the guidelines. Okay,
Okay,
because in
thank
Red Book, uh, they haven't mentioned anything about non-melanoma cancers. Okay, but in October exam, they have asked from non-melanoma cancer. So in that case, we have to follow another guidelines as well because it's not included in this guideline. Okay. Yeah. So before screening patients, not the patients actually, we do screen for the asymptomatic people, right? Asymptomatic people. If the patient is already having a disease, so there's no point of screening, right? We have to treat them. So the sorry. So the main purpose in here to prevent an early recognition of these cancers by screening them. Okay, so in this each cancer categories, the screening categories, first we have to divide these asymptomatic people into categories according to their risk, right? According to their risk, we have to divide them. Here you can see, here you can see the average risk, moderate risk, and higher risk. Okay, so we have to first identify the risk, then according to the risk factor, we have to do something. Okay, it's depend on the risk factor. This is what is in the chat. Yeah, and this guideline, okay, the same thing I have added in. This is it. Yeah, yeah. This is my recall group note because when I was discussing, I have made the chart so we can use that. Okay, so who are the average risk people? If you want, you can also take a screenshot. It's fine, doctors. Okay. So average risk. Who are average risk? So these are the people with no family history of colorectal cancer or one first degree relative diagnosed at age of 60 years or older. So what is the age? 60. Please remember, okay? Okay, so who are they? No family history of colorectal cancer or one first degree relative diagnosed at the age 60 years or older. Okay, then in here, this category risk is near average. Then who are the moderate risk people? One first degree relative diagnosed before 60 years or one first degree relative plus one or more second degree relatives at any age or two first degree relatives diagnosed at any age. Okay, so these are the three criteria. One is enough to categorize our patient as moderate risk. Okay, so who are they? First degree relative diagnosed before 60 years old. In here, the average one is 60 or older, more than 60. Okay, in here, moderate one less than 60 year first degree relative or one first degree relative plus one or more second degree relatives at any age or two first degree relatives diagnosed at any age. So these are the moderate risk, and here the risk at least two times higher than average. Okay. Then who are the high risk people? So high risk people are two first degree relatives and one second degree relatives with at least one diagnosed before 50 years. So who are they? Two first degree relatives and and one second degree relative with at least one diagnosed before age 50 or two first degree relatives and two or more second degree relatives. Then third one, three or more first degree relatives diagnosed at any age. So in these patients, the risk at least four times higher than average risk. Okay. So these are the higher risk people. So these are the three categories. So let's check what we can do for these people. So average risk people, in these people, asymptomatic adults age 45 to 74, we have to start from 45 and till 74 years. In here, what we should do is screening with immunochemical fecal occult blood test. Here, iFOBT, right? Here, iFOBT every 2 years. Okay, iFOBT every 2 years start from 45 years to 74 years. So please remember, iFOBT every 2 years, starting from 45 till 74, and there's no indication of colonoscopy in this average risk people. There's no indication, so you have to remember this. Then, moderate risk people. In these people, colonoscopy is recommended every 5 years. Every 5 years. Starting age is 10 years younger than the earliest colorectal cancer diagnosed in first degree relative. Okay, as example, you have to tell me. Son came that mentioning his father is diagnosed colorectal cancer at 55. Okay, 55 of his age, and he's in which category? He's in which category? I'm just explaining this one, okay?
Ma'am, moderate.
Okay, it's moderate, right? Because one first degree relative diagnosed before 60. And then the next question is when we should start to screen this child.
45 years of age.
Yeah, 45. Why? Because his first degree relative, the father, is diagnosed at 55. So here they have clearly mentioned 10 years younger than the earliest colorectal cancer. So the earliest colorectal cancer they have diagnosed at 55. Um, you have to minus 10 years from this 55. So that means 45 years. Or age 50 years, okay, age 50 years, whichever is the earliest, okay, whichever is earliest. So that's you should remember. And continue till 74 years. Then the higher risk people, in this case also colonoscopy is recommended every 5 years, and we should start this colonoscopy 10 years younger than the earliest colorectal cancer diagnosed in first degree relative. The same thing. Or age 40. Here, age 40. Here, age 50. Here, age 40. Whichever is earlier. Okay. Okay. Whichever is earlier. Okay. Yeah, okay, I'll give example. High risk patient and father diagnosed at 55. Okay, then the patient is in higher risk category. So when we should start the screening, patient is high risk, and when we should start the screening,
40.
Why 40?
And
Why
because
40?
the guideline says that we have to take the younger age.
Yeah, that's
Since father was diagnosed at 55, ideally 10 years younger is 45. But guideline
yeah,
says previous means the age at which first degree relative is diagnosed
mhm,
minus 10 or 40, whichever is lower.
yeah.
Since 40 is lower, we have to start at 40.
Yeah, that's right. So, so you have to think, okay? So don't confuse because the screening questions are like pure marks, okay? You don't have to think too much. You just need to know the actual guideline points, okay? Guidelines points. So you should know these ages, okay? That's the main thing here. Yeah, and in moderate and higher risk category, you should know the we can screen start from the younger than first degree relative diagnosed age, or in moderate age, or if age is 50, in high risk one is age 40, whichever is earlier. Okay, and so that's for the uh, low risk, moderate risk, and high risk patients. And we have something else. Okay, in when we consider colorectal cancers and refer to the genetic or familial cancer service, which cases? Because personal history of colorectal cancer diagnosed under age 50, colorectal cancer plus another Lynch syndrome. So what is Lynch syndrome? Tell me the example for the Lynch syndrome. What are the most common cancers in Lynch syndrome? Tell me, doctors.
Breast cancer, ovarian cancer,
Mm-hmm.
liver
Okay.
cancer, lung cancer.
Yeah.
It
Okay.
involves all organs.
Yeah. And you have to remember one more thing. Today, our topic is not the Lynch syndrome, but please remember for the Lynch syndrome, the most commonest cancers are in Lynch syndrome, the most commonest one, okay? Colorectal cancers and endometrial cancers. So these two are the most commonest cancer. And other than this, we have ovarian cancer, bladder cancer, stomach cancer, small intestinal cancer, liver cancer, kidney, brain, anywhere, okay? Because it's Lynch syndrome, right? Yeah. Then, what about Okay, we will discuss about Lynch syndrome later. Later, mean in another day. Today it's not our topic. Then, um, Yeah, and colorectal cancer plus another Lynch syndrome associated cancers. Colorectal cancer is a strong family history of colorectal endometrial cancer. Okay, that's that they have here also mentioned that, especially diagnosed under age of 50, and family history of multiple relatives with colorectal or Lynch syndrome associated cancer. So in that case, regardless of the age, we have to refer them for the genetic counsel. Okay, you will see the questions when we are doing e-medicine. Okay, so remember this one as well. Yeah, that's all for colorectal cancer. The same thing they have mentioned here, doctor. I have added in shorter form. Okay, here the same thing. Yeah, and they have mentioned about something. It. Yeah, the colorectal one every 2 years. Yeah, colonoscopy every 5 years. So you can give it a rate here. That's the main thing you should remember. Okay. And they have mentioned about mhm, yeah, doctor. The same thing. Yeah. Yeah, okay, this one. Okay, I'll explain that part as well. Okay. Here, chemo preventive trials for calcium, some vitamin supplements, selenium, and statins have provided mixed evidence of benefits. The strong evidence for benefits has emerged for observational studies, exposure, and non-steroidal anti-inflammatory drugs, especially aspirin. Result from randomized control trial about the use of aspirin in primary and secondary prevention of colorectal cancer and adenomas are now available and point to a similar benefit that associated with the screening by colonoscopy in patient aged less than 70 years. Aspirin is an affordable and accessible option and has other benefits such as cardiovascular protection and relatively no significant side effect. Although these side effects increase in with age, it's important to note that the benefits for aspirin in cancer prevention become apparent after latency period of 10 years, and it is less studied in older people, especially women. So they have find out aspirin has the prevention of the cancer risk. Okay, so that's all, doctors. For the okay, we will do some questions for colorectal cancer. Okay, give me 1 minute. Select it and let's do it. We have 44 questions. I think it's all for the screening and everything. And the treatment as well for the colorectal cancers. But I have to select only screening part. Give me so 1 minute. Sorry. Hello, doctor. I'm just selecting the questions because we have so much questions and uh, I have to select the screen. Give me 1 minute. Okay, I have selected few questions. Because these are very high yield and you can easily get the. Okay, let's do this question. Yeah, we just finished the colorectal cancer, doctor. Don't worry. I'll upload the video after this, okay? So you don't have to. Sorry. Okay. Um, a 37-year-old man present for the health check for insurance purpose. He does not have any current health issues. His medical history is unremarkable and he does not take any medications. His father developed bowel cancer at the age of 47 and two paternal uncles had the same disease at the age of 59 and 64. This patient need to be given some advice with respect to screening for bowel cancer. The place of fecal immunochemical testing, like iFOBT, and colonoscopy is discussed. Which one of the following is most appropriate screening plan? So, what is it? Type your answers. Okay, so type your answers. I need the answer A, B, C, D, O, E. You all going with C, right? Good. Yeah, you know the point. So why is it that? Explain the theory behind it. Who can explain it? Okay, here. In this patient. Do I need to explain? No, we can quickly move to the next one because we just discussed this, right? Mm-hmm. Yeah, doctor. Yeah. Okay, here the same thing they have mentioned. That's the thing. Yeah, you can do after session as well. Okay. Here, anyway, I'll read this part. Colonoscopy starting 10 years before the diagnosis of first degree relative is recommended for patient at moderate risk of colorectal cancer. Yeah. Okay, we just did this same kind of question. A 45-year-old woman present to the GP clinic seeking advice on bowel cancer screening. She has no symptoms of concern, however, is concerned since her father was diagnosed with carcinoma of the rectum at age 65. She has no significant medical history and take no regular medications. On examination, she appears well with vital signs within normal limit. So, which one of the following is most appropriate advice? So, type your answers in the chat. We got A's and D's. So, tell me which category is this patient? Is average, moderate, or high risk? Tell me that before. Mm-hmm. Here, 45-year-old woman present with, and here his father was diagnosed age at 65. 65 mean when? More than 65, we take this patient as average category, right? Yeah, more than 60. So our patient is 65. So that means average category. In average category patients, what we should do? What we should do, doctors? Yeah, you are correct. Mm-hmm. Yeah, good. Mhm. Yeah, yeah, our
Ma'am, could
patient
you
is.
just after this discussion just show that part of your notes where the guidelines were written?
Yeah, what doctor?
Ma'am, that note that you had made
Okay,
and you asked us to take the screenshot also. I
okay.
could take just the first part where they
Yeah,
were
okay. No,
classified.
no. I'll send it in the group, doctor. It's fine. I'll
Okay,
send
okay,
it.
ma'am.
Okay. Yeah.
Thank you, ma'am.
No worries. Each patient is average risk, right? So don't make any confusion. Okay. These are very easy and you can easily take the like full score for this question. Okay. So don't confuse. I explained because some doctors has marked it as moderate. So this is not the moderate. This is average risk. Okay. I'll show it again. Here, one first degree relative diagnosed at age of 60 or older, these are average risk and FOBT every 2 years starting from age 45. Okay, age 45. So please don't make any, sorry, make, what happened? Yeah, okay. Don't make any confusion. Okay, I have explained that's what one, some doctors have marked it as a moderate risk. Okay, and now patient is already 45. The patient can start it from now. Yeah. Mm, no, this is not important for today. So 35-year-old man present to the GP clinic for health check and he enjoys good health with no GI symptoms and he has no significant medical history and take no regular medications. Family history include father developing bowel cancer at age 55 and maternal aunt who had the same disease at age 50. He asked about the screening for colorectal cancer. So what is the answer? Type your answers in the chat. Mm-hmm. Just give me 1 minute. Okay. Yeah. Yeah. Okay. So you all going with D? Why D? Tell me. Why D, doctors? You have to answer me.
Ma'am,
Mm-hmm.
moderate risk and
Mm-hmm.
first degree relative was diagnosed at 55.
Okay. Good.
So we have to subtract 10 years from that and compare
Okay.
it with 50. Since 45 is less than 50, then so we have to start it from
Yeah.
45. And moderate risk has guidelines to do colonoscopy every 5 years. So 5 years, colonoscopy every 5 years since 45.
Yeah, good. Perfect. That's how you should think. Okay. Next one. Don't know how other questions also saved. I think I previously saved. Yeah, not this. Yeah, here. A 42.
Actually, e-medicine filter is a bit faulty, I think, today because I was doing heart failure questions and it gave like something not at all
Yeah,
related.
doctor. AMC, nothing is very friendly with AMC, right? But this e-medicine also their recommended guidelines. So AMC is partnership, so it's not friendly, right? Yeah. It's not user friendly. Even TG also not user friendly. Yeah, that's AMC doctors. A 42 years old woman present to the GP clinic seeking counseling regarding screening for bowel cancer. She is completely asymptomatic and has no digestive tract symptoms. She has no significant medical history and take no regular medications. She is very concerned because her 70-year-old mother has recently been diagnosed with colorectal cancer, and it is the first person in the family to have developed the disease. She would like to undertake further investigation. So, which one of the following is the most appropriate advice? So, what is it, doctors? Okay. What is
Weak,
this? What category is this, doctor?
average.
Mm-hmm. Okay, you all going with D. Good. Yeah. I'm not gonna read it, okay, doctor. We know the theory, the same theory because they are not changing because screening guidelines are all same. It's all from Red Book. Okay. A 30-year-old man visits GP requesting screening for bowel cancer. He has no current symptoms of concern. His brother was recently diagnosed with small intestinal cancer at age 37. His sister died at age 45 from the pancreatic cancer shortly after treatment for ovarian cancer, and his father diagnosed with colorectal cancer at age 45. The patient has no significant medical history and take no regular medications and work as a groundskeeper. Is non-smoker and maintain healthy diet. So there's no abdominal masses or tenderness. So what we should do? That's the next step. Mm-hmm. So what we should do? What is the answer? And you have to give some hint why you should why you should select this as the answer. Why doctors? Why we should refer this patient for the genetic counseling? Why? What is the suspicious here? What syndrome?
Lynch
Ma'am, Lynch
syndrome.
Yeah,
syndrome.
Lynch syndrome, right? You can see this exact guideline from the red books, right? So here, refer for the genetic. I'll read this part only. Okay. The patient present with striking family history suggestive of Lynch syndrome with three first-degree relative diagnosed with Lynch syndrome associated cancers at young ages. So refer for the genetic risk assessment is the most appropriate next step. So it's easy, right? Yeah. Okay. Okay, one more question. No, that's not our today's topic. I'll explain when we do in the Lynch syndrome and yeah, familial adenomatous polyposis syndrome. You have to differentiate these two. Okay, I'll explain once we are doing those topics. Okay, that's for colorectal cancer. Doctors, give me 1 minute. I have to stop the recording.